when you have membranes that rupture before the onset of labor. Now, PPROM means preterm premature rupture of membranes. So this is when it happens in a preterm pregnancy. So the only difference between the two is that one happens at term but before the onset of labor. The other one is in a preterm baby but before the onset of labor. So there's several causes. One, it can be just, it just randomly happens. And that's oftentimes what happens. It could be an infection that causes the membranes to rupture. History of a previous preterm birth will cause a PPROM. Some type of fetal abnormality could cause it. Overdistension of the uterus, for example, if the mother has twins, or if there's some polyhydramnios, poly meaning many, much,
Overdistension of what?
the uterus. So excessive amniotic fluid could cause it. But most of the time, we don't know what causes it. Now, complications, well, it depends on when it happens. Of course, an infection, I mentioned that could be the cause of ruptured membranes, but that could also be from ruptured membranes. They could develop an infection. But the other complications you have to think about are, particularly like if you have a PPROM, we've got a preterm baby. And most of the time, not always, but oftentimes, when the membranes rupture, labor will soon follow. So if we've got a preterm baby and we've got the membranes are ruptured, then we have to expect to plan for a preterm birth. Okay? Now, if we have a term baby and the membranes rupture before the onset of labor, what they will do is just wait for labor to begin and or go ahead and start some Pitocin and get the contractions going. The main thing is, let's talk about just the prom first. This is a term baby, and we would like the baby to be born within 18 hours of the membranes rupture. So they may wait a couple of hours to see if the mother's going to go into labor on her own. If she doesn't, they'll decide to go ahead and start Pitocin. On a PPROM, this is our premature baby, it's another one of those things that we wait and watch. If the baby is really preterm, we would like to wait before we initiate any kind of Pitocin or anything to stimulate labor. My daughter had premature rupture PPROM at 28 weeks. So there was no hurry. Even though I had told you that 18-hour rule, the rule we're working with now on a PPROM is, does the baby look okay? Is the mother showing any signs of infection? So if the baby's okay, it's premature, mother's not having any complications, we're going to keep that baby in as long as we can. And she actually kept him in for 2 weeks. Okay? Now, there are some things that will happen if this baby, either a prom or a PPROM, doesn't deliver within about 18 hours, then we'll give the mother some antibiotics, and we will give the baby some antibiotics after they're born. Okay, now this is prophylactic to prevent any type of infection. The amniotic sac protects the baby from any type of infection. So once that amniotic sac is broken, it is at risk for developing an infection. And that's why we say 18 hours. We would like the baby to be born. Now, if it's been 18 hours and the mother's pushing, it's not like they're gonna stop and immediately go run and do a C-section because we've hit the 18-hour mark. But the baby will get antibiotics in the nursery. Okay? So our biggest worry about with these is really those signs of infection. Also, once the membranes have ruptured and the woman is in the hospital, we will be taking her temperature every hour. Now, let's say, for example, in my daughter's situation where she was there for 2 weeks, they didn't do it every hour. So they did it every hour for the first day or so. And then, since she wasn't running a fever, they were gonna keep her in the hospital, they weren't gonna induce her or anything, then it went to every 4 hours. Okay, but during the acute phase of that, you will be checking it every hour. So again, we're gonna monitor for infection, any labor signs, and any fetal complications. So, preterm labor. Now, I'm gonna give you these statistics, I'm gonna talk about them, but you don't have to write them down unless you just want to. I'll never ask you statistics. I just want you to understand the implications of these statistics. So, in, let's see, what year was it? I guess it was in the late 80s. I can't remember exactly, but you know, that's been many years now. The preterm birth rate in the state was around 11.1, something like that. So let's just round it to 1990. What is that, 36 years ago? Something like that. Look at the difference right now. In 2022, the U.S. preterm labor rate was 10.5. We've gone down a point, not even a whole point. In 26 years, 36 years, whatever that math is. Believe it or not, I teach math. But anyway, which is surprising to me, and think about all the technology that has changed in all those years, all the research that has been done, all the improvements that we've made in healthcare, but yet we cannot get that preterm birth rate down anymore. And you can see in 2011, so, and this was 22 statistics, so 11 years, it went up. In Alabama, our rank is 13.1%. So you know what letter grade Alabama has? F. The infant mortality rate is 7.2 in Alabama, and this is either a 6 or an 8. It's a 5. It's a 5. That's why you never trust reading something without your glasses. It's 5.4 in the United States, and it's 7.2 in Alabama. Preterm birth by race and ethnicity, Black is still leading the preterm birth, 16.7. And I think this is per, now, I don't know, 100,000, I think it is. Well, anyway, 16.7, just to compare. White is 11.2, Hispanic 10.6, and Asian Pacific Islanders 9.6. In Alabama, the preterm birth rate among Black women is 50% higher than the rate among all other women. And that statistic has stayed, I don't know about the 50% higher, but it's always been higher in the Black population. So I said our rate in 2022 was 13.1, and it just says change in the rate from last year worsened. So 22 was even worse than 21. So again, I just wanted to give you an idea of where we sit with preterm births and how we have really may have signs of labor, but sometimes they're more subtle than just the obvious contractions where she's like bending over in pain. She may have just some mild cramping or heaviness in the vagina or backache. Her membranes may rupture. She may have an increase in discharge, vaginal discharge. She may just feel different. Now, if she's had a preterm birth before, she might recognize these signs as signs of preterm labor. But in any case, if we know somebody's at risk, especially if they're at risk, we need to tell them the signs to be looking for and to notify their healthcare provider as soon as possible. They may also have some diarrhea also. So we have some goals that we would like to attain for preterm labor. So the first one is to predict those at risk. So I told you some of those signs or some of those manifestations and some of those people who are at a greater risk. So we need to make sure that anything we can change, we will. For example, if they have frequent UTIs, we need to figure out why they're having frequent UTIs. Although pregnancy does cause you to a greater risk of developing UTIs. But we need to see what we can do, things we can teach them about ways to prevent UTIs. What signs and symptoms to report. Number 2, identify preterm labor early. So again, telling them signs and symptoms to look for, when to call the doctor, see them more often if they're at a high risk. Our third goal is to to stop the preterm labor. Usually, if they're 3 centimeters or greater, we're not going to try to stop. Now, there might be some exceptions. If we have a really preterm baby, we might try to stop it long enough to do our goal 4, but probably if they're regularly contracting and they're already 3 centimeters, we're probably not going to be able to stop. We also have to think about, is there any reason why we shouldn't continue this pregnancy? In other words, if mother has a rip-roaring infection and she's in preterm labor, well, it's probably going to be a better place for this baby outside the uterus. So we have to make sure that there's no reason why the pregnancy shouldn't go on. They are going to be on limited activity. Bed rest may not be necessary, but it depends on how much or what their signs and symptoms are, how much they're contracting, how far dilated they are. And they will be most likely in the hospital until they deliver. Not always. Some of that is dependent upon some of those things I mentioned, like how far dilated they are, how far pregnant they are. Another thing that can cause contractions is dehydration. So we want to make sure that they are hydrated, giving them lots of fluids. But remember, there's always that risk of pulmonary edema. So if you're going to be given a lot of fluids, you need to be checking for that pulmonary edema also. So I said that we would try to stop the preterm labor. So that's called tocolysis. Tocolysis. Toco meaning contraction, lysis means to break, stop, defeat, all those things. So, according to the literature, but I would bet you that nurses would disagree with you, the medicine that we use to stop preterm labor really, according to the literature, only really helps for a couple of days. But I've had many patients who we've had on tocolysis and have gone many, many weeks without delivery. But nevertheless, tocolysis, we're usually going to start off first with constant is the same about the magnesium sulfate. You're gonna do the DTRs. Your antidote is the calcium gluconate. Okay, so we're not gonna really go into that drug. But this, I wrote on here knowing it's very small, but I was just putting this on here so you can see what the new research says, is that they really only want you to use it for up to 48 hours, and it's for preterm labor, and this actually says, less than 32 weeks, and, short-term prolongation of pregnancy to get the steroids in it. That's what our goal 4 is. Prevention and treatment of seizures, that was for the preeclampsia. Okay, so, the only thing you really need to know about that truly is that it's not recommended more than 48 hours. But like I said, I was just letting you read how they came to that decision, and the new policy, or the new guideline, I should say. So, we've got this, which is acting as a smooth muscle relaxer. The uterus is a smooth muscle, and that's how it stops the contractions. After they decide to, or when they decide to switch from the IV tocolysis, they will start a PO type tocolysis, but they'll start it before they actually DC the other stuff, so that we have something on board the whole time. Okay? So, calcium channel blockers like nifedipine. Watch for orthostatic hypotension. No grapefruit juice while on nifedipine or calcium channel blocker. And then beta adrenergics. Terbutaline is a drug, and I just read a couple weeks ago, actually, that the FDA is saying do not use terbutaline anymore. It's actually used more for an asthma drug, beta adrenergic asthma drug. It was used off-label. You know what off-label means? It was used as it was not intended. But they had success with it, and we used it. It did have a black box label, but now they have said, don't use it at all. Does anybody work in OB? You? Do you know, are they still, ordering terbutaline?
I haven't seen that one.
Okay, all right. I don't know when this research came out, but I just found it a couple weeks ago. And I know it's recent.
So they probably still are, but from what I know.
Okay.
I gave someone terbutaline at my clinicals.
Mhm.
OB clinicals.
In OB? Okay,
For Grandview.
okay, so they still are using it. Well, it's been recommended by the FDA to don't use it. That's all I say. Anyway, it already had a black box warning, so that wasn't good anyway. Okay, so that's what we're gonna do for our third goal, to try to stop preterm labor. And then our fourth goal is to accelerate fetal lung maturity. And I put that maturity in quotations, because that's the words you will hear, but we're really not doing anything to mature the lungs. What we're actually doing is we're building up more surfactant. Okay, so it makes the lungs act like they're more mature. So, I mentioned that 48 hours is about what the research says that you can slow labor, a couple days. Well, that works out well because that's what we need to get these steroids working, okay? So, the physician may order, or midwife, may order either betamethasone or dexamethasone. As you notice, the SONE labels it, or methasone, whichever way you want to look at it, but that labels it as a steroid. The difference is dexamethasone, but they're both, approved, and they both are steroids. So that improves the amount of surfactant that's working, and that's what gives us those mature lungs, okay? So if we can hold off the labor for at least 48 hours, then this will allow us to get the steroids on board. We like to prolong the labor longer, but even if research has shown that it's only delaying it by 2 or 3 days, at least we can get that on. The benefit lasts about 7 days, and it's not recommended to repeat. So once the mother has this, if she doesn't deliver within 7 days, we're not gonna repeat this. All right? When you're taking care of women, in preterm labor, of course, we want to, manage our, tocolysis. Make sure you get the steroids on board quickly, because we don't know when our 48, we don't know when she's gonna deliver. We wanna make sure we have at least 48 hours to help with that lung maturity. Also, you're going to remember that what? Psychosocial issues, again, because this mother may be in the hospital for weeks. You know, we just don't know. Okay. Diabetes. Or as they say in the South, the sugar. So, the most important factor for a positive outcome is euglycemia, keeping that blood sugar within normal range. Another thing that's important is this value of time in range, TIR, time in range. When you're at the hospital doing clinicals, you are on your med-surg or OD, whatever, if you've got a diabetic, you are checking blood sugars, 7, 11, 5, and 9, or somewhere in there to do sliding scale, okay? So you know what the blood sugar is at 7, at 11, at 5, and 9. We have no idea what it is at 9:45, right? Or 4:30. We only know it when we actually check it. So it is recommended, highly recommended, that all diabetics get a continuous glucose monitor, so that we can see how much time are you actually in euglycemia. So recognizing the value of the time in range is also important to maintain positive outcomes. Okay? Early in, or around 16 weeks, the need for insulin increases, so we need to be monitoring these patients closely. Now, for type, well, maternal, let's see. Okay, management. All right, so for type 1 diabetics, they will continue their insulin. They need to make sure that they are talking with their diabetic doctor, or the doctor who's managing their diabetes. It's always a good idea to get pre-pregnancy counseling, because there may be some things specific to those patients that the patient needs to know or needs to take care of, or, hey, your blood sugars have not been in control for the last year. This is not really a good time for you to get pregnant, and this is why. So that's always a good plan. But, if you have a type 2 diabetic who is taking PO medications for their diabetes, they have to switch to insulin. They cannot take POs during the pregnancy. So diet, what kind of diet would they be on? Huh?
Low carb?
Well, not necessarily low carb. The reason I asked you this question is because I had a question on the test, and it was, one of the things was about the diabetic diet. Now, I have always grown up knowing, and I bet if you ask any one of your instructors, they will know this too, ADA diet. Have you ever heard of an ADA diet? Okay, well, I had that as an option, and nobody picked it. like, I mean, that's like an obvious, how can you not pick it? And they all said they didn't know what an ADA diet was. I have looked up ADA diet and we don't call it that anymore. So, I just wanted to know what you call it. It's a diabetic diet, but I don't know what you call it, okay? So if I put something on a test, I'm just gonna call it diabetic diet, okay? Because there are ones where you count carbs, and that's how you figure out how much insulin you get. It's not necessarily a low-carb diet per se, but you gotta account for your carbs. So we do know they need to be on a special diet, but I just don't know what we call it, yes.
Like, where the, you can eat whatever, but you have to count the carbs, and then, I think they do that, or like school nurse thing for the kids, that we're not, yeah, carb conscious. So,
Well, that's what I'm talking about, that carb counting, that you have to account for the number of carbs, but I don't know if they're doing that for everybody, or whatever. I need to get better acquainted with what the terminology is, but I looked and I couldn't find anything, so, anyway, I don't wanna confuse you, but if I say something about diabetic diet, then you know it's whatever's prescribed for the diabetic, okay? Okay, let's see, what else? So, insulin, I've already told you about that. Delivery, ideally, we're gonna deliver them by 39 weeks. We like to deliver just a tad earlier, just because there's complications that can occur with diabetics, and we'll talk about some of those. So maternal effects of uncontrolled blood sugar. They're going to have ketoacidosis, more likely. More UTIs. We know that bacteria in the bladder and urethra and all that, they love sugar. So if we have uncontrolled sugar, we're gonna have that. Premature rupture of membranes. Fetal effects. Early in the pregnancy, if we have uncontrolled blood sugars, we're gonna have a greater risk of spontaneous ABs and congenital defects. Because this is when the baby is developing, okay, growing, or fetally growing, okay? So uncontrolled in early pregnancy is spontaneous abortion and congenital anomalies. Later, uncontrolled blood sugar, it's going to be fetal macrosomia. That means large baby. And then we've got complications that come with that we'll talk about in a newborn section. You also have placental perfusion problems and calcifications of the placenta. So if you have calcification of areas on the placenta, it's just like an abruption where that area is not working. Now, the fetus can stand small little bitty calcifications, but if you're getting a large area, that part of the placenta is not working. Okay?
What was the first one? First fetal effect?
Macrosomia, large baby, excessively large. When you hear about these mothers having these 11-pound babies, they probably have diabetes, type 2 diabetes. Or diabetes that's been not managed well. Okay, neonatal effects, hypoglycemia. These babies have been used to getting all this sugar. We now have removed their sugar, but their pancreas is still producing that insulin, so they're gonna develop hypoglycemia. Hyperbilirubinemia. And respiratory distress syndrome. Now let me tell you about a story. I was taking care of a patient one diabetic, ketoacidosis. So she said, yeah, go ahead. No, I know. What did I check? No, I checked her urine first. Cause I was checking for protein. Oh, she also had high blood pressure. That's what it was. She had very high blood pressure. So I said, I wanna check her urine for protein. Well, of course, the sugar showed up as 4+ or whatever the highest was. So then I said, can I do a blood stick, finger stick? So she said, yeah, so I did a finger stick. Well, it was too high for the machine to read, and the machine was set at 600. Okay, I thought, whoa. So I said, can I get them to run, they had blood in the lab. I said, can I get them to run the blood they have in the lab? No, you gotta call the doctor. Call the doctor. Now, it's like 7 o'clock in the morning, and apparently he wasn't gonna get up early that day. Cause I woke him up, and he wasn't happy. And he's, yeah, go ahead and tell them to run the blood in the lab. So they call with, an emergent, blood result. Her blood sugar was 1089. In all my years, I had never seen a blood sugar that high in somebody be alive. I said, oh my God. So I said, come up here and redraw it. I just knew there was something wrong with the blood that had been sitting in the lab. It came up and it was 1092. So I had to call the doctor. Well, believe it or not, that doctor was mad at me. He said, you have just opened up a whole can of worms. Well, yeah, but I saved your patient. So anyway, we had to start insulin and all that stuff. So I got to thinking backwards. She was 32 weeks gestation. This baby was absolutely perfect. So what do you think happened? What did I just tell you about the placenta? Calcified placenta. Okay? This baby got no oxygen. And it just, yeah, it does. So this baby came out perfectly normal. So I went and looked at her chart. I said, there's no way she had a 1-hour blood sugar. Oh, we haven't talked about that yet. A 1-hour blood sugar or a 3-hour blood sugar that was wrong. Looked through the record. She had an elevated 1-hour blood sugar, so she did go for a 3-hour blood sugar. Every one of her values were sky high. No note on there that the patient had been notified. Nothing notated that anybody looked at it, except somebody did handwrite it. So I went in there, her mother was with her, so I just casually asked, did she have a blood sugar, doctor? Yeah, and she had to go for that one where it took 3 hours. Did anybody call you all about the results? No, we never heard anything, so we thought everything was fine. Now, here's 2 lessons there. Number 1, if they did call her, they didn't document it, so guess what? They didn't call her, as far as the law is concerned, right? Because the mother said, no, they never got a call, and they have nothing to prove that they called. The other lesson is, you make sure when you get values like that you don't just sit around and wait for somebody to notify. You go ahead and notify them, or if you're not the right person, you take it to that person right away. I don't know if that doctor ever knew that. And of course, I didn't say anything to the parents, to the mother or the patient. But technically speaking, they had a very good lawsuit on their hands. But anyway, nevertheless, that was the values. So we had to give insulin. You know, I thought, this is the one time I really thought that my patient had coded, and I woke him up with my scream. I don't think I brought him to life. Because she ended up, she had delivered. And the bed was up for some reason. I forgot what we were doing. Anyway, we were lowering the bed, and I was looking at her, and she did not look like she was breathing. And so I put on the call light, and I said, I need help in here now. Then the patient died. And so I think I probably pulled her out of her coma or death, whichever one she was about to go into. Anyway, when I left, they were transferring her to the ICU NICU. And then I heard the next day they transferred her, this was in Georgia, and Emory Hospital in Atlanta was our big major center. And so they were transferring her to the, heart, to Emory for a heart-lung transplant. Remember I told you about her blood pressure? And her pulse was high. The nurse that was taking care of her was actually listening to her pulse instead of the baby's, because her pulse was so high. Anyway, that was a terrible day in my life. No, I'm surprised she didn't die either. But I think the only thing that did save her, if anything, was that she was young. She was 18. I don't know if that made a difference or not. But anyway, the fact of the matter is, we can't take these things lightly, and you've got to develop good assessment skills. Had I not checked her urine or anything else, we would have gone on. Now, I promise you, I would have checked that heartbeat to make sure it was hers and not the baby's. But we may have let her go on, and who knows what would have happened. Hopefully, I would have picked up on other signs. But anyway, okay, so, gestational diabetes. Okay. So, testing. First of all, gestational diabetes is diabetes that is diagnosed during pregnancy. Again, the name gestational diabetes includes discovered in pregnancy. About 35 to 60% will develop type 2 diabetes in their lifetime. So the way we do this is we do a test at about 26 to 28 weeks. We do a glucose challenge test. We give a 50-gram bolus PO. It's like a very sweet, syrupy drink. And then 1 hour after that, we draw their blood sugar. If the value is greater than 140, then they have to have a 3-hour glucose tolerance test. So if it's greater than 140, on the screening, the glucose challenge test is a screening test. So if it's less than 140, we say see you later. If it's greater than 140, they have to have the oral GTT. So what they do here is we have them fasting when they come in, and we draw a blood sugar on them fasting. Then we have them drink 100 grams of glucose. And we draw their blood sugar at 1 hour, 2 hours, and 3 hours. So we have 4 values we are looking at: a fasting, 1 hour, 2 hour, and 3 hour. To consider them to have gestational diabetes, first of all, we look at their fasting blood sugar. If their fasting is greater than 95, they're considered gestational diabetic. If their blood sugar, their fasting blood sugar, is less than 95, then we look at the other 3 values. If they have 2 out of 3 of those values elevated, then they are considered gestational diabetic. Okay? So the first criteria is if the fasting is greater than 95, doesn't matter what the other values are. They're considered gestational diabetic. But if the fasting is below 95, then 2 out of the 3 other values elevated is considered gestational diabetic. So those values are, we said fasting was less than 95. A 1 hour, we want less than 180. same as a type 1 diabetic, okay? And I've already told you if they're on PO meds, they've gotta go to, if they can't control it by diet and exercise, then they'll have to go to, insulin if they need some assistance with the blood sugar. Vaginal D group strep. At about 36 to 37 weeks, when the mother comes into the office, they will do an exam on her, and they will actually get a vaginal/rectal swab, and they will test for GBS. Now, everybody has GBS, but what we're really looking for is an overcolonization of GBS, okay? So if the test comes back positive, we're not gonna do anything now. We're gonna wait till she's in labor, and then we're gonna treat her, and we're also going to treat the baby. We're basically treating prophylactically to make sure that, that the baby doesn't get Group B strep. And we're treating the mother so that hopefully as the baby comes down, and delivers, especially the vaginal, that the baby won't get the infection. Penicillin, ampicillin are drugs of choice. If we don't treat the newborn, it can cause several complications in the newborn, this Group B strep. Including, fetal death, or newborn death, if we don't get this baby treated. They can get sepsis, pneumonia, meningitis. Now, there may be other situations, like we talked about with the ruptured membranes greater than 18 hours, where we're gonna treat the mother and baby, with these same drugs. So this is not the only time we will treat mother and baby, but this is one of the times. But I didn't want you to think we would never, I didn't want you to think that automatically if a baby's being treated with penicillin, that the mother must have had Group B strep. There could be other reasons. So again, we don't do anything for the mother until she actually is in labor. Now, twins, you don't have to know anything on this slide here. I just put this up here so that you can see, the difference in, twins. Identical twins are from the same egg that splits. And depending upon when it splits, it will become one of these, or may become one of these. And then, your fraternal twins are two totally different eggs. That's why fraternal twins can be opposite, gender. They can be same gender, but look totally different, because they're just like two different pregnancies, okay? But, some of these are greater complications. For example, this one here, you see, because they're in the same sac, and they've got one placenta, you see the cords right here, these babies can play jump rope with each other, if the cords tangle. So this one, now it says here 4% of babies are like this, but this one is probably the most complicated, or can be the most complicated one. Here, they're at least in their own sac, so we don't worry about that. This can also have what's called twin-to-twin transfusion. One baby can take more of the blood than the other baby, and it can cause a fetal death of the other baby. My great nephews had this. They had to be, my niece had to go to Miami and have a surgery at 15 weeks gestation so they could ablate some of the blood vessels, because Jackson was taking all the blood away from Justin. And even today, even though they're identical twins, you could tell the difference. One is bigger than the other. But anyway, she had to have that surgery, and they actually went into the uterus and ablated. But had they not caught that in time, then it's very possible that Justin could have been a fetal demise. They named him Justin because he got out just in time. And they were delivered at 32 weeks. But anyway, I just wanted to show you that, you know, the difference in in the way the twins can be. You don't have to know that, I'm not gonna ask you that. But I am going to comment on care. There are several risks, to the mother, stillborn, gestational diabetes, preeclampsia, anemia. By the way, incidentally, my nephew, it was his wife who had the Justin and Jackson. Shortly thereafter, my sister had 2 children. Josh, who was the father of those twins, and then Amber. Incidentally, Josh's wife had twins, and my niece had twins. And they were both identical twins, and they were both males. And whereas all this happened to my nephew's wife, my niece, she went to 39 weeks. Both babies were over 6.5 pounds each. And she is shorter than me and more petite than me. So it was really kind of ironic how they totally different situations. But anyway, okay. And the reason I thought about that is when I said anemia, she had problems with anemia, but really that was the only problems that she had. Okay, so risk to the baby, well, I mentioned some of depending upon how they are, what kind of twins that they are, but also preterm births is gonna be a big factor that we look for. That cord around the neck is another issue. And then how we deliver, well, I'll talk about that in just a second. Okay, monitoring. You've got to make sure that when you're monitoring these babies, that you're monitoring both babies. Okay, you wanna make sure that you're getting 2 distinctly different heartbeats. Because it's real easy to put the, ultrasound, that transducer on the belly and think you're getting 2 different heartbeats and they're in 2 different places. No, you can pick up the same heartbeat. So you gotta make sure you're monitoring both of the babies. Also, you need to be prepared for the fact that you may have, well, you're gonna have preterm, if she's there for preterm labor, that you may end up delivering a preterm baby, so you gotta be prepared for that. Notify the NICU of admission, because they need to be prepared that they may be getting some, if they're preterm. Most twins will not go to term like my niece did. Okay, most of them will deliver a little bit earlier, or they will be induced, because there are several complications that can occur right at the end if we let the babies go too long. So, we wanna just make sure that we do that. Now, how are we gonna deliver these babies? Well, that's gonna depend on several things. Number one, the provider is the big decision maker. But what the provider's gonna take into consideration is, are both babies head down? Or is one of them breech? The problem comes in with what's the biggest part of the baby that has to deliver? Well, not really, I mean, yes and no, but the shoulders go like this, and we also get them up underneath the pubic bone. What's the biggest part? Head is the biggest part, right? So, if we get a breech baby, and we get the butt out, and we get to the chest, and we maneuver the shoulders, like we can, what if the head won't fit? So, oftentimes if it's breech, if one of them is breech, they're not gonna deliver vaginally. We're gonna take the safe way and deliver by C-section. Now, let's say they're both head down. What can happen if I deliver one of them? What can the other one do? Whew, he's got all this room now, right? There ain't no telling how he can turn. So that's another consideration they might take. In fact, how big are the babies? It's another thing. My niece had both of them had a C-section but for different reasons. My niece that had the 2 big fat babies, it was because of what we said. the fact that they were worried they could flip. The preterm babies they did because if you've got really preterm, you don't want pressure on the head, okay, because that can cause ventricular hemorrhage. And so they may choose, even if it's a single pregnancy, but if it's preterm, they may choose to deliver C-section. But anyway, so there's several factors. They may deliver the first one vaginally in the OR and just be ready if the second one happens to flip. There are still some doctors that will go in and do a manual flip if the head, you know, if they happen to flip. I don't know if the younger doctors these days are doing that, because I don't think they're teaching that much in the medical school, just like forceps. I don't think they're teaching that, or at least that's what the doctors were telling me. They're not teaching that in school, in medical school anymore. But anyway, so there's no right or wrong answer for me to tell you that these babies are always delivered C-section or always delivered vaginally. It's gonna there's a lot of factors that come into play there. Okay? Okay. How's about, before we go on, that's all of Nancy Carter. Whoa. Okay, I hope there was somebody in here who always woo-hoo. Who's the that always woo-hoos? Maggie? Somebody named Maggie? Margaret? Okay, well, I heard somebody was woo-hooing because Dr. Hicks was asking me if she was doing it, and I said, well, I must not be as exciting as she was.